Hello, everyone. I'm Dr. Theresa Sevilis, and we're going to be talking today about Alteplase to treat or not to treat. I'm going to go ahead and get started pretty much on time here because we got a lot to talk about. Just a quick little introduction. I'm a board-certified neurologist and vascular neurologist. I did my residency at Kaiser Permanente, Southern California, and I did my vascular neurology fellowship at UNC Chapel Hill. I've been with TeleSpecialists since 2017 and a regional medical director since 2019. I have no disclosures. Today, we're going to touch a little bit on the variations in practice with Alteplase, as well as the indications, and spend the majority of the time on the relative contraindications, but also go over the absolutes too. So when we think of medicine, a lot of times there's really set rules as to when to do things and when not to do things. And treating with TPA is a little different in that area. And there is a lot of variation in practice, things certain neurologists are comfortable with, things that others aren't. And because there is a lack of evidence in randomized controlled trials for a lot of things, you will see a difference between a patient that one neurologist would treat and another might not. And we have, the guidelines that we're going to go through here that help us with, but they are just that, they're guidelines. They're not hard, steadfast rules. So this chart here shows you some up to 50% variation in the treatment of different conditions, with a secured aneurysm down to an oral anticoagulant with an INR greater than 1.7, in which there really was no variation in this particular study. And when we really think about the decision we're making, is you're weighing the bleeding risk versus disability for this particular patient. And every patient scenario is also different. And the viewpoint of that neurologist can potentially be different too in weighing those risks and benefits and kind of coming up with a decision as to whether or not it's right to treat them or not. So the most recent guidelines that were put out in 2019, here we have the indications to treat. As we're going through these different guidelines here, the way I like to think of it as there's red, yellow, and green, kind of like a stop sign, a stoplight. The green is go ahead and treat. There's no reason to even consider not treating in these patients. The yellow is slow down. Let's think about this. Let's look at the story. Let's look at the story of the patient. Let's look at their individual history and think more about it and talk with the patient. And red is stop. These are clear reasons we shouldn't treat this patient. So you'll see those colors going along the tops of the guidelines as we go through the presentation here. The indications that we have on the slide here show you that within the 3-hour time window for patients who are older than or equal to 18 years of age, they should be treated. Initially looking at the 3-hour time window for that is a very clear-cut answer. And then where it goes into the 3 to 4.5 hour time window, that's our ECAS-3 criteria. If they meet that criteria, again, it's the very clear no-brainer green light. We should go ahead and be treating these people. No need to discuss it further. And we'll talk a little bit more about those ECAS-3 criteria when we get to them in the relative area. The blood pressure requirement is being less than 185/110. Now, if you're not starting there, it doesn't mean you can't get somebody there, but if they have to be under that number in order to treat. And this is one that we often hear some confusion on, is the blood glucose. This most up-to-date guidelines say anybody over 50. There is no longer that greater than 400 in there. It's just simply saying over 50, we should be treating. The CT scan needs to be done, as we all know. And if they're on a prior antiplatelet, whether that be a single antiplatelet or dual antiplatelets, we should still go ahead and treat those. They're not anticoagulants. And while it may come with a small increased risk of bleeding, that risk would be outweighed by the potential benefit of the treatment. And patients with end-stage renal disease with a normal PTT should also be treated. Now we get into the long list of the gray area, where we have all these relative contraindications that really require us to slow down and think some more. So there's this page, and this one, and we're going to get through all of those today. And then we have our contraindications, the red light, the reasons not to treat. And we will go over those in a little bit more detail now too. So we're going to have an interactive part to this where we get to answer some questions and poll the audience and see who would treat and who wouldn't treat. So this is the first question that we have in here. This is a 103-year-old male with a history of AFib, not on anticoagulation, who is presenting with 2 hours of speech changes and right-sided weakness. The NIH is 12. Would you treat with IV Alteplase? Okay, and it looks like we have, oh, we're still voting a little bit. 73% right now saying they would treat, and 26% saying they would not treat. So now we'll get into age. As we said in that first slide there with the greens, that 3-hour window, it is very clear that anybody greater than 18 should be treated. If they are less than 80 versus greater than 80, we do know there is some difference in the potential amount of benefit a patient could get simply because patients who are older don't tend to do as well as patients who are younger. So if you compare them to their age-matched peers, we do still see benefit, and that is the reasoning for treating that population. And it really is the same in that 3 to 4.5 hour window. When you go farther from the onset of symptoms, we know that treatment for anybody, despite your age, is not as effective potentially as it is to treat them early, which is why we're always pushing to get those draw to needle times down and treat patients as soon as possible. But just because they can't benefit as much doesn't mean they don't still have potential to benefit and be in a better condition than they would otherwise. So anyone who is greater than 18, we should be considering for treatment with TPA. Now looking at the time window, this is where we'll look a little bit more at that ECAS-3 criteria. So the criteria there were greater than 80, which we just talked about as being considered safe and effective now and something we should still be doing. Then the history of diabetes and prior stroke is also considered to be of potential benefit and something we should consider in this 3 to 4.5 hour window. Severe stroke symptoms. Severe stroke symptoms are likely not to do as well simply because they are severe, but it doesn't mean they can't still have a potential to benefit. While it's considered uncertain in the guidelines here, I think they're just because you're so sick doesn't mean you should get ruled out as having a chance. So personally, I don't consider that to be a contraindication. And mild disabling stroke, it is also considered reasonable to treat within the 3 to 4.5 hour window. So when we say consider, it's now really the time window is 4.5 hours for everyone, and we should at least be considering. Just because they have a potential reason that they could not do as well as others doesn't mean that you can't have that conversation as part of your discussion about getting treated with the patient and make sure that they understand that they may not fit the NINS criteria that with those potential risk factors, but that doesn't mean that they still don't have a chance to benefit even if their risk may be slightly higher. And adding on to the time window would be wake-up strokes. Now, as if we haven't tried hard enough to get 4.5 hours from last known normal into people's heads, now we have this new curveball thrown out there of 4.5 hours from symptom onset as a potential means of treating patients. This does require have an MRI and an acute MRI, which most facilities don't really have the means to do. So while the wake-up trial did show us by randomizing 503 patients with acute stroke symptoms of an unknown onset time, within 4.5 hours of that symptom recognition, they used what we call a mismatch on MRI, which means that the diffusion restriction on MRI is present, but the flare sequence is normal. The exclusion criteria for this study were that the DWI lesions weren't larger than 1/3 of the MCA, the NIH wasn't greater than 25, they had no other contraindications to Alteplase, and they weren't planned to get a thrombectomy, because then we wouldn't really know the benefit if they got a thrombectomy. The study was stopped early due to a lack of funding, so it didn't reach the goal of 800 patients. But it did show that the modified Rankins of 0 to 1 at 90 days was 53.3% compared to 41.8% who didn't get the Alteplase. So it shows that this can be of benefit, but we need to be doing it in places that have the correct protocols in place and the ability to do so, which is just far and few between in hospitals right now, but something to certainly work towards being able to do in the future so we can help more people. So here's our next question. I have an 82-year-old female with a history of dementia who's living in a nursing facility, presenting with left gaze, right-sided weakness, and aphasia. The last normal was 2 hours ago, confirmed by the nursing facility, and her baseline function is wheelchair bound, but with the ability to carry on simple conversation. The family wants to do everything. Would you treat with IV Alteplase? Okay, it seems like the number stabilized there. So we have 89% of people saying yes and 10% of people saying no. So pre-existing disability. The kind of stance the guidelines are taking, and what I think a lot of neurologists take on pre-existing disability is, we're never going to get somebody who's a modified Rankin of 2 to a modified Rankin of 0. That they're starting from the best they're ever going to be. But if that gives them a good quality of life and they are happy with where they're at and their family is happy with where they're at, then it's worth trying to maintain them there. So if the supports are in place, if the caregivers are in place, as they put it, the goals of care all align, there isn't a reason that we shouldn't be offering these patients the same standard of care that we offer everyone else. And this goes for dementia patients as well. If their life expectancy is there and they're able to do some sort of functions, we should certainly be offering them that option. And so kind of the first part of what I said there. And we also know that there is, while limited, there is some data that's showing that there isn't an increase in symptomatic ICH in people with worse baselines. So it's definitely an opportunity to find out the goals of care of the patient and the patient's family and consider what potential gains they could get from treatment. And that also takes into account how severe their symptoms are. Okay, so next we have rapidly improving symptoms. So strokes fluctuate. Some patients can get better, get worse, go back and forth, and it can fluctuate for hours, weeks. People have different presentations. So if somebody initially presents with a moderate to severe stroke and improves to mild but still disabling symptoms, there is zero guarantee that they're going to continue to improve. They could end up right back where they started. And if you decide not to treat them, they may then be out of the window and unable to treat. So just because somebody has improved is not a reason that we should not still treat them. Now, if they have resolved, that is a different story. If they have no symptoms left, then certainly we shouldn't be giving them a medication just because they were severe initially. So that if there's any disabling symptoms left, we should still be treating. And here's our next case. We have a 65-year-old female with a history of AFib who's not on anticoagulation, a stroke without any residual deficits, and seizures, who presents with a witnessed generalized seizure 2 hours ago, and ongoing aphasia, right-sided weakness, and left gaze preference. Would you treat with IV Alteplase? It seems like we have a little bit more of a split on this one. 53% of people said yes, and 46% said no. So seizure can be put in that category with what we call stroke mimics. Now, stroke mimics can be a whole lecture in themselves, so we're just going to touch briefly on this here. But we do know that, especially in somebody, as in that patient who has AFib, you can throw a clot, and if it hits, you hit the cortex of the brain is where you get the stroke, they can actually cause a seizure at onset. So just because somebody's had a seizure certainly doesn't rule out stroke. Finding out more about if they have a history of seizure, do they have a typical postictal period? What are their seizures like? Those things are certainly important in making the decision, because if they're having a common postictal phenomena for them, we certainly don't want to treat them if it sounds very much so like that's the case. If this is a first time that they've had these types of symptoms, then we certainly should be concerned for a stroke. And if they've never had a seizure before, even more so with these symptoms. The other stroke mimics can be very challenging with patients with functional symptoms, with complex migraines, to really tell if the symptoms are real. And sometimes you can feel that those symptoms are more functional, but I'm sure many neurologists can tell you how they've been burned, where they thought that patient was functional. And while a good portion of it was, there is some underlying true weakness. So my general rule of thumb for these patients is, if I can't prove normal, I'm going to treat. If I can get them to show me, maybe they don't hold their arm up, it drifts down, but in a functional appearing way, but then I see them reach out and grab something and hold somebody's hand or do something different out. And you'll often probably see us trying to get patients to do other things and kind of trick them into showing us that they can do it normally. And if they can do that, that's one thing. But if I can't get them to show me that they can function, I have to give the benefit of the doubt that it actually is a stroke, because if we don't treat, we can't go back in time and treat them. And there are various different studies now showing between a 0 to at the highest 1% risk of bleeding complications in a stroke mimic. So with this low risk of hemorrhage, it's certainly not worth permanently disabling somebody with a stroke that we missed and could have treated. And here's our next case. This is a 74-year-old female with a history of AFib on warfarin, who's presenting with right-sided weakness and dysarthria. INR is 1.7 and PT is 14. The last known normal is 1 hour ago. Would you treat with IV Alteplase? Okay, it looks like we have 68% of people saying yes, and we just switched to 65 saying yes and 34% saying no. Okay, so when we talk about coagulopathy, our cutoffs for patients who are on warfarin is an INR less than or equal to 1.7 and less than 15. So this patient does meet the criteria for treatment, because the INR was exactly 1.7. Those greater than and equal to, the greater than and the less than and equal to can certainly make this confusing when you sometimes see it as less than 1.8 or greater than or equal to 1.7. So but these are the numbers that we do go by. So the contraindications are the platelets being less than 100,000, the INR greater than 1.7, PTT greater than 40, or PT greater than 15. An important thing to know with these numbers is that there is no study evidence behind them. They are expert consensus, and there is various case reports and literature you can find. There are a few just to mention. There's one case series of 21 cases with platelets less than 100,000, in which there was one symptomatic ICH. which would be 4.7% of patients. Another study with 115 on warfarin with an INR greater than 1.7. And there was, again, one symptomatic ICH in that, which is only 0.8%. And another study with 164 patients with a PTT that was prolonged. And in that one, there were 6 ICHs, and that's 3.6%. And when you go with the NINS trial, we're quoting a 6% hemorrhage risk. So those numbers are all less than that. So you may see in certain physicians, including myself, that if a patient does come back with an ever so slightly off number here, but a very disabling stroke, I don't always stop the TPA. Sometimes it's a conversation with the family of, okay, your platelets are 99. You have no history of that. You had another lab recently. This may be a lab error. This may be a slightly increased risk of bleeding, but you're aphasic. Do you still want to be treated? And I have certainly done that and continued treatment on patients that were slightly off from these numbers. Now, most neurologists probably don't do that. You probably do see a lot of people who are more sticking hard and solid to these cutoffs. But if you do see some people doing that, that's why, is because there really is no evidence that that exact number makes a difference. And really, there's evidence to the opposite in the cases where people have fudged it. And I can tell you when I fudged it a little bit, I have never had a complication with doing so. So doing it with informed consent, discussion with the patient, and an understanding, and only for severe symptoms. Nobody would ever consider that for numbness or something like that. So then we have the history of anticoagulants use. So the IV glycoprotein 2 B3a inhibitors. This category is a little confusing as to what to do because abciximab is a contraindication, but the others in the category we don't know. So I've had this question, come up from various people: would you treat? And I generally stick with, if we have a contraindication within the class, I'm going to say no for right now until we actually see any sort of safety data that you could treat within this class, which we don't have at this time. So I'd stick with a no on that one. One of the common questions we have come up is low molecular weight heparin. So a full treatment dose in the previous 24 hours is a contraindication. We do not treat those patients. But if they're on DVT prophylaxis, we can go ahead and treat those patients. That is not a reason to withhold care. We don't have to wait for the labs on that. The DVT prophylaxis is okay. So we do go ahead and treat that as normal. So for those, our nurses at our bedside, if any of you are on here, you may hear us asking, are they on Lovenox? If so, how much? Because we do need to figure out if it is that DVT versus full dosing to decide if we can treat them. And the thrombin inhibitors and factor Xa inhibitors, the guidelines currently say if you've received a dose within 48 hours, not to treat. The side note is that if you have a normal PTT, INR, platelet count, eccrine clotting factor, and thrombin time, or a direct factor Xa activity assay, then you could treat if they were all normal. That is not feasible to get in most acute situations in real time practice. So generally, it's just the 48-hour rule, and nobody's really pushing to try to get all those labs. That is typically not something we can get done in that timely of a frame. The new thing is that there was a recent study which had 80 patients who were on dabigatran that were reversed, and there is 0 reported bleeding in those patients. So down the line, may we see that change? Is there possibly going to be reversal of these agents? It's possible. It's an early study, and it's not enough findings that anybody's changing their practice right now, but it may be something we see in the future here. So it's worth noting. Next, we'll talk about dural and arterial punctures. So the kind of put these together because they both used to have preceding 7-day contraindications, which have gone away now. It's considered reasonable to treat a patient who had a lumbar puncture within the last 7 days. There may be a risk of a hematoma at that site. I do usually still mention that potential risk to a patient so they're not shocked if that were to happen, but it's not a reason we can't treat them. You can decompress things and be keeping an eye on it. And the same goes for arterial punctures. I think a lot more have been done because of the thrombectomy procedures we're now doing, which kind of ties in that next point here, procedural strokes. Now that we see doing these procedures after TPA, that you can control the bleeding at that groin site. You can put pressure, you can use femstops. There's other ways to keep that bleeding uh, under control should it occur. So particularly with an arterial puncture, there are times in which I'll say, okay, you just had a procedure. Can you grab a femstop, put that on while we're getting the TPA, and we'll just do it preemptively to try to prevent that hematoma from forming, and we can go ahead and treat them. And there, it's also being considered that if you've had that cardiac cath or the cerebral angiogram, as long as there was no medications administered and there's no other contraindications, that those punctures themselves should not be a reason we don't treat, because sometimes they can potentially be the cause of why the stroke's happening. So we don't want to exclude them. Okay, on to our next question. We have a 45-year-old male who's inpatient for a colon resection that occurred 10 days ago, and he now has aphasia and right-sided weakness. Onset was 2 hours ago. Would you treat with IV Alteplase? Okay, so on this one, it looks like we have 55% of people saying they would and 44% saying they wouldn't. So talking about recent surgeries. So recent major surgeries is in this gray zone again of discussing what's going on and what the surgery was and what the potential bleeding risks are. So this is a time in which our surgical colleagues are our best friends. We very much so need them to weigh in on what can they control. And it's kind of my general rule of thumb is if I think somebody's symptoms are bad enough to consider, then I try to get the surgeon on the phone and see what they think and if they could control bleeding should it happen. I've been surprised in a few cases, and people in times when they said yes they could. I remember I had one thyroid surgery and I thought with the airway and everything right there, they're like, no, I can handle it, go ahead and treat them. And in this situation of a colon resection, that's usually a no, because the intra-abdominal cavity, you can easily bleed out and not be compressible and not necessarily be able to find the source of bleeding. Again, if a surgeon said that they could, that would potentially be a different scenario. But intra-abdominally, I have yet to have a surgeon say that they would be able to control and wanted me to proceed with treating. But everyone's different. So it's worth having the conversation and asking. Now, intracranial and intraspinal surgery within the last 3 months, that one I'm a bit more of a stickler on, as are the guidelines. Anything intracranial surgery is an absolute no-go. Spinal surgeries, depending on how far out and what the surgery was, I will often, again, reach out to the neurosurgeon and see what they think. I have had a few cases kind of usually later in that like 2-month range, in which they have felt that they could handle things and the stroke symptoms are worse enough and they have a good understanding of stroke too, that they did say that they would keep an eye on them and handle it if something did occur. And I have treated in less than 3 months on a spinal surgery. But again, it's very specific to what that surgery is and the comfort level of the surgeon in that postoperative period. And recent trauma. So this is when we really need our medicine colleagues, whether that be internal medicine or ER doctors, to help us weigh these benefits and risks here. Because the risk of the trauma, the location of it, how high a risk of bleeding is really something we don't always know, because sometimes we haven't seen the whole trauma workup. Trauma surgeons can also help us here too. But it's, again, weighing those risks and benefits. Somebody who has numbness, we're not going to treat that if they have a recent significant trauma. If they have severe aphasia, severe weakness, it's a totally different story where it may be worth considering if the potential risks of are not as high. I can recall one patient that I did treat that had recent, I think it was a car accident, and had a dislocated shoulder, and it had not been addressed, but that shoulder was an arm that was already not in use because of her prior stroke, and it was pretty much flaccid. So there were some benefits there of if you had any local site damage at that dislocation, don't really matter because they don't use the arm anyway. So we did go ahead and treat her. So there are just because there is trauma doesn't mean we can't potentially consider treating. So it's again a discussion that needs to be had. Now, severe head trauma is a different case. Head trauma within 3 months, it's a contraindication. Typically, in order to be called a severe head trauma, there's likely some bleeding and contusions and various things if you fit in that category. And we really don't want to do that because we're going to make things worse. And the same thing with the acute head trauma. You're likely to have a more significant event there, and that bleeding risk is certainly going to be too much to play that risk and benefits game. And the other thing to think about here, though, is when you see acute head trauma, it's not the bumping your head because you fell down. I mean, we wouldn't be able to treat about half our patients, I think, if we ruled it out for every head bump. The number of patients I see fall from their stroke weakness and happen to hit their head a little on something, patients say yes to that question often. But if we can't see any signs of trauma on their head, there's no bruising, there's no obvious significant injury, then we can certainly go ahead and treat those. Just because their head did get hit in some degree, it is not enough to completely rule them out there. Okay, this is our next question here. Of a 60-year-old male with a history of hemorrhoids who is presenting with flaccid weakness on the left, onset an hour ago. He's had a small amount of blood on the toilet paper 2 days ago and no history of significant bleeding requiring transfusions. Would you treat him with IV Alteplase? Okay, we have 87% of people saying yes, and that makes me very happy. I feel like this used to be more of a question mark when I first started training, and that people are much more willing to treat these patients now, which makes me happy. So, the GIGU question is if they have this history and it's very much so in the past, then there is no reason you can't reasonably treat them. If the bleeding has occurred within the last 21 days, then it's not recommended. But when we say a GI bleeding event or GU bleeding event, you're really worried about the fact that that tract goes to the external world. And if they start hemorrhaging, they can hemorrhage substantially. And so we're not counting when we get down to GI malignancies, we're not really counting the liver, the pancreas, the other organs. We're counting it the way in which you can bleed out of your body. So, a GI malignancy would be of the actual GI tract itself, like a colon cancer or something in the esophagus or small bowel or stomach, which you could have large scale bleeding that would be difficult to control if you couldn't access the tract. So those within the last 21 days, we certainly don't want to treat. If it's in the past, if it's been treated, and there is no reason to believe they would necessarily hemorrhage again, that's not a reason to not treat them. All right. Next case here is a 24-year-old female with a history of hypercoagulable state, not on anticoagulation, who's 30 weeks pregnant, and she's presenting with aphasia and flaccid right-sided weakness onset 45 minutes ago. Would you treat with IV Alteplase? Okay, it looks like we have 62% of people saying that yes, they would treat. Okay, so now we'll talk a little bit about both menstruation and pregnancy. So, one of the things that I get told often, because my general question that I tend to ask patients after asking them if they've had any bleeding in their brain is, have you had any bleeding anywhere in your body in the past or current? And I will often get women say that they have very heavy periods, or that they're actively on their period, and is that going to be an issue? So regular menstruation is not a reason that you can't treat with TPA. Even those who have a heavier cycle, then you ask if they've had transfusions or anything like that that's been required in the past. And most of the time, the answers to those questions are no, and these patients are perfectly safe to treat. If they did have a recent severe bleeding requiring transfusions or anything like that, that would be a different story. But I have actually yet to find a patient who actually fits into that category. But we do want to make sure that if they bring up this history, that we're making sure they don't have a significant anemia, hypotension, or other bleeding issues there. For the most part, that should not be a contraindication. In pregnancy, we have limited data, but in a patient with moderate or severe stroke symptoms while pregnant, the thought is that the benefit to the mother outweighs any risk of uterine bleeding. In the postpartum period, which is less than the 14 days after delivery, that's really not well established. But when you talk to OB colleagues, which I often do in these situations, is obviously we need to bring them on board with the pregnant patient and make sure they're there to help support us and help us make some of these decisions. But for the most part, in that postpartum period, they have always told me, if that uterus is bleeding, I can always take it out. So if they have significant enough symptoms, then that would be their answer. And usually they do say, go ahead and treat. Not every patient's different, but it certainly is worth that discussion. Just a little bit more about pregnancy. There was the biggest literature review article I was able to find. It was published in 2017. There are no randomized trials that include pregnant women, and there is only one prospective study. So a lot of the evidence we have is all retrospective case reviews that have been put together in which patients were treated. So this particular review found 141 pregnant women that were having serious thrombotic events, and looking at the outcomes, there was 4 maternal deaths, 12 major bleeding episodes, 13 mild moderate bleeding episodes, 2 fetal deaths, 1 child death, 9 miscarriages, and 14 preterm deliveries. The conclusion that they made in this paper is taking into account that these are very sick women. These are serious thrombotic events. Whether they got treated or not, they were all in pretty life-threatening scenarios. And these risks they felt were quite reasonable, which is encouraging to see, because this is from OBGYN literature, that they were quite supportive of treating these women and giving them a chance. And just so you know, just because you had one of these complications, it doesn't mean these are all separate patients. Some of the same pregnancy with the fetal issues were all the same mother. So they're not all separate cases out of that 141. Okay, next we're going to move on to vascular abnormalities. So the extracranial cervical dissections are considered reasonably safe to treat within the 4.5-hour window and are, as I say, probably recommended, but really this is something that we do go ahead and treat. Now, an intracranial arterial dissection, there is this potential risk of subarachnoid hemorrhage from that, in which there always kind of raises the question mark of, is that something you should be treating? In reality, we don't deal with that situation very often because the CTA is not typically reviewed before we treat with TPA, and a history of an intracranial dissection would not be a reason to not treat a patient. It would really have to be case by case if you actually were in the situation when you had one you knew about. An unruptured intracranial aneurysm. So a small aneurysm, a small to moderate sized, which is less than 10 millimeters, that is unruptured and unsecured, is considered reasonable to treat. Many patients have these, and we find out afterwards on their CTA, and we don't see a lot of complications with that. If they've ever had the history of rupture, obviously they'd be ruled out because they'd have the history of ICH. And then for the giant unruptured, unsecured aneurysms, these are a little bit harder because we don't really know as well, and there's not as much comfort because we know the larger aneurysms have more risk of rupturing, but they also have the potential to have some turbulent flow within them and some potential clot that they could throw and cause further strokes. So that one is a harder question. And again, it'd be probably pretty case by case. How bad are the symptoms, and is the patient willing to take the risk or not? And also, if you know about it, because if it's not something that's been previously diagnosed, you may already treat by the time you find out. Other vascular malformations, there are quite a few, and really kind of a case by case basis. We don't have a lot of literature to support it. There are certain ones that we're more comfortable treating versus others, and that just needs to kind of be risks and benefits there. Aortic dissection, we know, is red, clear stop. We certainly don't want to treat somebody with an aortic dissection, and that's why we often do get those CTA tests to make sure if there's any sort of suspicion of that. And so moving on to cardiac issues, an acute MI, what we should be doing is, if they have an acute MI as well as their stroke, should be treating them with their Alteplase per the stroke protocol, and then having them taken for angio and stenting or whatever their other indications are for their cardiac procedure. That would be the ultimate goal, would be to get that stroke treatment in and then whisk them off to the cath lab. The recent MI, while there was contraindications here in the past, it really has now considered reasonable to treat all these patients with a recent MI. The likelihood of developing a hemopericardium from this is just not high enough that we should deprive these patients with just significant stroke symptoms of treatment. And when it comes to an acute pericarditis, that is something that we should discuss with the cardiologist. What is the degree of it, the severity, and kind of, again, weighing the symptoms and how severely disabling those symptoms are from the stroke standpoint. So that would be a kind of joint decision of risks and benefits with cardiology. A left atrial or ventricular thrombus, then they're saying severe disability, reasonable to treat, mild disability, uncertain. I don't think we'd end up in this situation very often, because if they come in with stroke symptoms and they have one of these thrombi that probably caused the stroke, we don't get an echo before we give TPA, so we wouldn't know about it. And then if the situation that you do know that there's a ventricular thrombus sitting there or an atrial thrombus, they're going to be on heparin, and then they're not going to be a candidate. So it's not a common situation to end up in, but I guess if you did, it's a matter of how severe is the stroke, and if you give them TPA, could you potentially throw more clots and worsen the stroke and not be able to heparinize them for 24 hours? So that's where there is some challenging decision making, but thankfully we don't end up in that position often. Other cardiac issues, such as a myxoma or a papillary fibroelastoma, these are things that are still considered reasonable to treat in the appropriate situation of the symptoms being worth it. Infective endocarditis, again, is our hard stop. We know that can increase the risk of intracranial hemorrhage, and we certainly don't want to do that. Okay, so another case here. This is a 56-year-old male with lung cancer who's presenting with right-sided weakness and dysarthria. The last known normal was 3 hours ago. He's on chemotherapy, and CBC, PT, INR are all normal. Would you treat with IV Alteplase? Okay, it looks like we have 48% saying yes. So for malignancy, systemic malignancy with reasonable expectations of greater than 6-month life expectancy, they say that the would be something we should consider. Now, it's really hard to kind of say that, so I tend to leave this up to patients and to how aggressive they are being with their care. If they are being aggressive and they want everything, they have a current functioning level that they want to preserve, and they want any extra month they can get with their family, then by all means, I'm happy to treat you. If they feel like they're at the end and the quality of life is not very good, and if they ended up with a disability, they'd rather have just passed and have the stroke be severe enough to do that, then that is a patient that doesn't make sense. So I think this is very much a conversation with the patient and the family about what their goals of care are and if they have any other contraindications. This is certainly a scenario where a lot of times we do need to actually wait for the labs as opposed to the general rule of thumb of not waiting unless there is a suspicion. So malignancy is one of those suspicions we do wait for to make sure. An extraaxial intracranial neoplasm, most common one, a meningioma, that is, assuming it's your run-of-the-mill regular meningioma and nothing complicated about it, we can certainly treat those patients too. An intraaxial intracranial neoplasm would have a hemorrhage risk intraparenchymally, and we certainly would not treat those patients. Ophthalmologic conditions can get complicated sometimes because it is difficult to say if I have, some sort of hemorrhage in my eye and that's going to get worse, but I can't move the side of my body. That would be a reason to say, okay, well, maybe you just accept the possibility of losing vision in that eye because the strength is more important. Whereas if it's numbness, it's easy to say, no, vision trumps numbness. So again, that is a discussion point with the patient. If they have significant symptoms, I certainly do offer treatment. And losing the vision in your eye is not something that's going to kill you, but it is something you would have to choose to deal with. So making sure patients are aware of that possibility if they have any sort of ophthalmologic process that could lead to that and having that discussion. I have yet to have a patient tell me no when they have weakness or other symptoms. Usually if they have these conditions in their eye, the vision is already so poor that if it was completely lost, it's not as big of a deal. But you never know. So having that conversation is very important. Now, mild strokes. So this is probably the one point in the red box that I have a little bit of trouble with because an NAH of 0 to 5, I have yet to meet an NAH of 5 that is not disabling. I don't know what that would be. So a non-disabling stroke would mean something that doesn't limit your ability to do anything. And I think there are various definitions depending on who you talk to. In my mind, it means that you could function the same as you could before. And if there are limitations, then those limitations are real and they count. I have seen people who laying down in a bed doing an NIH, they're a 1 for numbness, but you get them up and that numbness is significant enough that they can't walk right. Or they can't hold, they're right-handed, that's numb, they can't hold their keys, they're dropping everything, they can't take a drink. That's significant. That's still disabling. And I will happily treat that one. Posterior circulation with dizziness, you can sometimes have them be fine with dysmetria on an NIH, but you get them up and they can't stand. Again, a reason to treat them even with an NIH is 0. So it really, while the word non-disabling is the important factor here. And the definition of non-disabling is not so clear cut as just saying 0 to 5. That to me doesn't make any sense. It's a matter of what does the patient do? Does it upset them? Is it their what wouldn't they be able to do? Which is a great way to phrase it to patients. Is there anything you wouldn't be able to do right now? And some people have surprised me with the answers to that question. And other people say, I could do everything. It just feels funny. Well, it just feels funny is probably not worth the risk. But if there is a list of things that you can't functionally do at the moment, it's certainly worth treating. So this needs to be a discussion and clinical judgment and not based on a number. And here is our next case. I think probably our last case. It's a 65-year-old male with a history of traumatic subdural hematoma when he was in his 20s, who was presenting with right-sided weakness and aphasia that started 1.5 hours ago. His CT head is completely normal. Would you treat with IV Alteplase? Okay, and it looks like we are at 89% say yes. And that's a tricky one because I agree with you. I would treat, but technically, per the guidelines, there is no exception there. So we'll just kind of go over that here. Uh, Starting with our kind of relative contraindications, the cerebral microbleeds. Now that we have this great technology of MRI, we're able to see so much more and potentially try to predict who may be a TPA complication versus not. The number of times we see hemorrhages in the brain that are not in the location of the stroke mean that maybe these cerebral microbleeds may play a role in that. So there is a lot of research going on into this right now. So the guidelines are taking the current stance. If there's a small number of cerebral microbleeds, meaning only 1 to 10, then it's reasonable to treat. And if it's greater than 10, it's really uncertain, and there may be an increased risk of ICH. We don't really have solid enough evidence to really exclude people based on this. And oftentimes they present, you don't have their MRI in front of them, so you don't necessarily know. And if they haven't had a significant bleed in the past, will they've now? We really just don't know. That we need kind of more input on this. So at this point, I am not excluding people based on their MRI, but that's something that may get more of a foundation for the future and be able to give us some clearer guidance on if we should be. Now getting to the true ICH, obviously if they have an ICH at the moment, we're not going to give them TPA. If they have a history of an intracranial hemorrhage, that is considered a contraindication. My one exception to that is those long past histories of a traumatic subdural. If it really truly was trauma and not traumatic enough to leave any changes on the brain, and they've been fine for 40 years like that, I don't see why not to offer it to them. I do always throw the caveat in. There is a potential that your risk may be slightly higher because you've had this history. And if they're just numb, maybe not worth doing. But if they are significant symptoms, then certainly worth offering and considering. I have actually heard of somebody who did a case on this, a legal case, and the neurologist who didn't treat was actually held accountable for not treating in that traumatic subdural situation because the benefit was potentially there. So that is one that, while it doesn't fit in the guidelines, it's a pretty typical practice to still treat that patient. Obviously, a subarachnoid or intraparenchymal history of bleeding at any point in time would be a hard no. And a recent stroke. This is another slightly controversial one because while we have the recent stroke within 3 months, you do not treat. There are various case reports of people treating within shorter time frames without complications. And one of the main thoughts here is that if you have this healing stroke, that you're going to bleed into it. So that's one of the benefits of getting an MRI on TIA patients, is because sometimes they're not TIAs. Sometimes they were actually small to even moderate sized strokes, but the symptoms resolved. Now, if they have that moderate sized stroke, I certainly don't want to treat them. If they have a teeny tiny little dot stroke and they come back with very profound symptoms, risk and benefit discussion, it may be worth considering treating them. But for the most part, if we don't have any better history, we have nothing kind of out of the ordinary there, then that 3 months would be the rule. And just a few other things that are in there that I don't need to go into great detail about. Sickle cell disease, not an indication not to treat. We should still treat those. Hyperdense MCA signs, even more so, we should treat those and then take them for thrombectomy. And illicit drug use, we should certainly be treating those patients too. So other studies were referenced on the slides, but the guidelines are the main thing that I was talking about here. And there's the reference for that. And then we can open up to questions now.
Dr. Sevilis, you do have a question from David Schaefer. It is regarding if there are any guidelines for Alteplase with spinal cord infarct without aortic dissection. If no guidelines, what is your opinion on practice?
Yeah, there is really nothing that tells us that TPA is going to help in a spinal cord infarct. There really isn't a lot of great information. And normally, even if you were going to try to apply the 4.5-hour window, we don't really have confirmation of that. And there can be other things going on and getting spinal imaging. I don't think I've been in a situation where I actually could have treated somebody with a spinal cord infarct in that time frame. It is a point of research and that people do talk about often, but I don't really have a clear answer on it because there just isn't enough data. There certainly could be potential to help, and I think it's something to consider, but it's just not a common situation to get into. Do we have any other questions? I see one popping through here. Do you have a sense of what is considered a reasonable rate of stroke mimic treatments with IV TPA? I don't know that I've really seen it taken as a reasonable. The hard part is you don't really know, and every patient is so individual with stroke mimics. It potentially does depend on your hospital itself. Some hospitals, depending on your location and the demographics you serve, may have a higher rate of functional patients than others, and that wouldn't be a bad thing. Yeah, I never really think about it as a percentage of patients you're treating that are stroke mimics, because you just don't know. Every case is individual. Okay, so if an MRI shows a big stroke, would you ever not treat with TPA? Also, if you see a minor hemorrhagic conversion on MRI, would you not treat with TPA? So if you did get the MRI quickly, by seeing a big stroke, the difference would mean, is it completed or not? And that kind of goes to that wake up protocol. I've had a few scenarios in which I was able to get a very stat MRI, more so back in my training days, where we would look at that very acutely in particular situations. And if you have a large DWI lesion, that would certainly be a reason to treat. If that DWI lesion is matching the flare, and then you're not going to benefit that patient, and that would be a reason not to treat. So the stroke size wouldn't so much be what would change my opinion if I had an MRI. It would more be if it is completed versus non-completed. Because at that point, your MRI with that mismatch is very similar to what we're doing with all these perfusion scans now. You're actually seeing is that dead tissue already. And if the whole thing's dead, there's no reason to give TPA. And the MRI is even a little better than our CT perfusions at showing us that. It's not common to have flare changes go away. I'm not going to say impossible, but not common. And if there is any hemorrhagic conversion, no, I would not give TPA if I saw any hemorrhagic conversion.